Well, good morning again to everybody. I know there are still some people popping on and some chat things already happening. So we are so glad y'all are here. Again, this is the third and final part of our series we've been doing about necessary conversations. Excuse me. And we are recording today's program. We've recorded the whole series. You will also receive the recording link, but you'll also receive, excuse me, the handouts from today's presentation and past handouts from the series and a follow-up email this afternoon so you don't miss out on anything. We are offering free CE credits for nursing, social work, and licensed professional counselors. You get 1 CE credit hour for each part of the series that you've attended. You must attend the live program and be present for the full hour. And you will receive an evaluation link in the follow-up email this afternoon. And once you complete that evaluation, you will receive your CE certificate for today's class or today's session. Please allow us about 5 to 7 business days to get you that CE credit once you have completed the evaluation, and each evaluation closes within 30 days. I will also send out the evaluations from the previous sessions. If you attended those live and just haven't done the evaluation and want your CE credit or an attendance certificate credit, please do that and we'll make sure you get those certificates. Again, my name is Jamie. I'm with the James L. West Center for Dementia Care, and we are a nonprofit organization that serves persons that are impacted by dementia. And we do that in various ways through our residential care. We have a building here close to downtown Fort Worth. We're able to serve residents either at a full-time capacity or at a respite stay. We also have a senior adult day program. It is currently closed because of COVID, but we're hoping to get that open sooner than later. And it's a great program for the community. And then we have our dementia and caregiver education, which we offer free of charge to families that are managing this disease wherever they may be, as well as healthcare professionals. And we're happy to offer CE credits for free to healthcare professionals and also to collaborate with great organizations like Community Healthcare and Care and Prepare, whom we've heard from through this series so far. Is Leah here? I'm sorry, I don't see anybody. Leah, would you like to talk about Care and Prepare?
Thanks so much. Really appreciate it, Jamie. Honored to be a part of your panel today. So what we do is we help people have those awkward conversations. We help them bravely face what are their really true desires and goals that they have for their life. And we do that with people that are healthy and for people that may be experiencing a crisis in their health. So we're grateful and thankful to be here. We help stimulate end-of-life conversations through a lot of educational events. We have many, and we're also beginning an exciting new partnership with Vinca Healthcare, which is the world's foremost expert in advanced care planning and electronic healthcare records. So our goal is to provide all Texans with advanced care planning and the ability to retrieve those decisions by their family and by clinicians so they can get just the right care at just the right time. If you don't tell us what your wishes are, we can't honor them. Help us help you.
Thank you, Leah. And I am going to share the screen about Community Healthcare if you want to share that, and then I'll start sharing so y'all can take over and do our program today about having the hospice conversation.
Thank you so much. Go ahead, Erin.
Yeah, I'm just going to share just for a minute about Community Healthcare of Texas. We have been serving the community the last 25 years. We're the largest nonprofit offering hospice services in North Texas. And we do serve 25 counties in Texas. And our vision is to provide compassionate care for those living with a terminal illness and also give support to their family. We like to provide care wherever the patient calls home, and that can be their private residence, that could be another family members, that could be an assisted living, nursing home. And we also have 3 inpatient facilities in Tarrant County where we can provide for crises when there's symptoms that we need, giving IV medications or providing nurses at bedside to control those symptoms. Medicare primarily pays for hospice, but we do provide care to many patients that don't have insurance or a way to provide, don't have a payment source. So that is one of the things that community hospice is able to do. I'm gonna let Dr. Godfrey introduce herself.
Hi, I'm Dr. Karen Godfrey. I've worked with Community Healthcare of Texas for the past 14 years. The last 4.5 of which have been in the Chief Medical Officer role. We are very lucky and honored to have one of our inpatient units on the 4th floor of the James L. West facility. So, you know, now that COVID's easing up, feel free to come up and visit us.
There you go.
Okay. So today we are going to talk about having the hospice conversation. Erin and I, of course, our only disclosure is that we both work for Community Healthcare of Texas. Our objectives are going to be recognizing hospice patients, talking about how these conversations can be difficult, and then to explain the SPIKES acronym and how it applies to a hospice conversation, and then talk a little bit about how we can collaborate more effectively with hospice transitions. Like I said, we both work for community healthcare.
I'm going to start out. I'm very passionate about having an early hospice conversation and the value of that. Some of the most, I've served as a hospice nurse the last 8 years, and some of the most frustrating situations are when we're in the middle of a crisis and we're trying to have a conversation about hospice and how it can help, but we're having to do so much work to manage the crisis that it's very difficult to have the conversation and for the family to participate. So this kind of got touched on last week in the hospice overview. I'm so grateful for that. That was an excellent job Holly did. But 80% of Americans say that they would like to die at home. That's a pretty big number. Unfortunately, 60% of Americans die in acute care facilities. 20% die in skilled nursing, which can be an incredible benefit and for many people is considered their home. Only 20%, around 20% actually die at home. And so where's the gap? I think the gap lies in the fact that we have a very hard time having difficult conversations and talking about death here in America. And my goal, my hope for almost everyone I know, for my family, for the people I work with, is that the H topic, the hospice topic, or death would become much easier to talk about, that it would not become an off limits conversation that we only have when we have a couple days left to live. So why do we have it early? What's the value of the hospice conversation? I believe it helps patients maximize the quality of the end of their life. I got into hospice because three out of my 4 grandparents had hospice experiences at the end of their life. The total number of days that these 3 grandparents spent on hospice was 12. So that would mean that was an average of about 4 days for each of them. So if you can imagine, it wasn't the full hospice experience that they could have gotten. Studies have shown that if families and patients get 3 months on hospice, they're able to utilize really all that hospice has to offer, which would be symptom management, help from psychosocial services, and a lot of grief care. The next thing is that if we have an early hospice conversation, the patients can participate in the discussion. They can talk about what they want at the end of life, what their goals are, how they want it to look, what would be their ideal for passing the last days to months of their life. Next would be that it allows family time and support they need for the changes in the grief. One thing we've seen during COVID is deaths happening, people not having any time or any resources to process their grief, to come to grips with what's happening and to work through that. And often when hospice comes in late, or when we haven't talked about it sooner, that process is really rushed or skipped. And as we know, grief doesn't just go away. We have to have ways to deal with it for us to move through it. So having this conversation early gives the family and the patient time to work through this. Hospice seeks to honor the dignity of the individual while creating beautiful, positive moments. A lot of people think that hospice means giving up hope. We say the word hospice and it feels like, a lot of people feel like that means I'm giving up hope. I would argue that it actually gives opportunity to create hope-filled experiences and beautiful moments for family. Because of the support that comes in, we're able to help people finish very well at the end of life. One of the major things is that pain and symptoms can be addressed early and even before they arise. There's a lot of symptoms that come at the end of life. We all think of pain usually when we think of the end of life, but honestly, I would say anxiety is an even bigger symptom that we're dealing with at the end of life. I've probably helped and been with, I don't know, 2,000 to 3,000 people at the end of their life. And I've only had 2 or 3 that I thought had no anxiety. The rest of the people had some anxiety just knowing that there was a massive change coming for them and their family. But hospice is able to come in and offer resources to help people deal with that and avoid major crises. Next, and I think one of the biggest, especially when we're talking about dementia and Alzheimer's patients, is that we can reduce trips to the ER. There's no one that I would less want to have to spend time in the ER than someone struggling with dementia, or really anyone that has any major illness, because of the risk for them and because of the stress for them. So hospice being available 24 hours a day provides an amazing resource to families, to nursing facilities, to Alzheimer's, memory care units, because we're able to be the emergency room person. The nurse can come out or they can triage over the phone. Next would be just that, and this, I love all that Leah has shared about the advanced directives, but it's so good if we start these conversations early, then it gives people time to designate who they want to help make their decisions and what they want done for them and what they want that to look like. And then my last point on the value of the early hospice conversation really has a lot to do with weary caregivers and family members. When we are able to offer this benefit, which is ideally a 6-month benefit, that's what Medicare says that people could get, which would be 180 days of help. When we're able to give that a lot of times it tremendously takes a weight off the primary caregiver and off the family. Many times people are already exhausted and maybe not even doing very well physically themselves. But when we are able to come in, we're able to offer them respite. A lot of times that family member can go and rest for 5 days while their loved one is being taken care of. So I think that hospice is an incredible gift. We're all going to die. And I'm a runner. And I'll tell you, I've run a few races where there wasn't any water along the way. I've run a few races where honestly, I was in one race where I didn't even know where the finish line was. And I was just kind of running, looking for it. It is so much better to finish a race with help, with support, with people at the finish line with their arms wide open, ready to give you a hug, with people cheering for you. And I mean, I'm relating that very much to the end of life. If we can, as much support as we can offer people at this time, the better. I'll hand it over to you, Dr. Godfrey.
So how do we know when it's time to have the hospice conversation? That, I mean, if you ask my kids, I've all told them, I'm like, I've already had the hospice conversation with my whole family so that they know, call them in when it's time for me. But how do we, as caregivers, as clinicians, know when it's time? Because honestly, estimating the amount of time that a patient has left to live is tough. And studies have shown that the closer that you are to a patient, the more likely you are to overestimate the time that they have left to live. There's certain things, and that I'll discuss, but the big question is, would you be surprised if this family member or if this patient was still alive in 6 months? Would you, right now, thinking of patients, would you be surprised if they made it to Christmas? And if you're surprised, if you would be surprised, then they might be appropriate to have the hospice conversation.
And I want to add in that we do rely a lot on our intuition in those times. And just it's not an exact science at all. And so a lot of times it's like we've seen a gradual decline and we can anticipate that they very likely might not be around to that holiday 6 months from now.
So if patients are needing more assistance with their activities of daily living, if they have shortness of breath, even, moving from bed to the bathroom, shortness of breath to the point where they're having difficulty eating, multiple recurring infections, UTIs, pneumonias, aspiration pneumonias, multiple falls. And then sometimes they're kind of borderline, you're thinking, oh, they might be appropriate, but they have a whole lot of other comorbidities, diabetes, heart disease, many other things that may contribute to their overall decline. Unexplained weight loss, frequent medication changes, changes in mental status, skin breakdown, and then, like Erin was saying, numerous emergency room or hospitalizations. That kind of gives you puts the idea in your mind that, hey, this person might be on perhaps the final decline. Neurologic, they can have increased difficulty swallowing. They may need to go from a regular diet to a pureed diet, from regular liquids to thickened liquids. Or they may be coughing, choking, and having aspiration events and aspiration pneumonias. Urinary infections or sepsis because of that, or pressure injuries because they're not moving, they're more bedbound. Those signs kind of let you know, hey, maybe it's time to have that conversation. The shortness of breath with conversation. Sorry, Erin, go ahead.
I was just going to add to that, even if we notice that they're sleeping a lot more than they were, maybe they only used to take 1 nap a day and now they're taking 3 to 4 naps a day. Those would be maybe some things that would alert us that there's been some significant changes.
Exactly. And like we said about looking in the future and the surprise, would they be alive? Sometimes it's good when you're thinking of these conversations to think, how were they 2, 4, 6 months ago? And what changes have you noticed? Increased edema, shortness of breath, and just needing a lot more assistance.
So going into these difficult conversations, once we've identified that we've seen a significant decline in someone, and maybe at least someone's brought up hospice, or you in your head are thinking maybe it's time to start having this conversation with this family or with this patient. Going into it, I just have a few tips. I have these conversations a lot. And get the opportunity to talk to lots of families about end of life and end of life care. And I still, to this day, if I'm pulling up to visit with a family, I take a moment to pause and really just to remember my own mortality and to be at peace with my own death and dying. And that's helpful, I think, when we're even when we're thinking about having conversations with people or we want to get better at it. I think it is important to think about our own conceptions about death and dying so that we can peacefully go into those conversations. Next, I would say that really the way that we look at it as far as having the conversation is very important. I remind myself that I am giving them a gift. I really do believe that by having the conversation, I'm offering them something that otherwise they might not know about or receive and be able to get the full benefit of the services if I don't tell them about it. I'm often surprised that I'm the first person that people have talked to hospice about. And then I'm surprised that people didn't know about the full breadth of the services. So think about it as that you are giving them a gift by sharing with them about hospice. I find often, and I'm being really honest, I do get anxious before these conversations. I think it's a very stressful situation to go into, to unleash other people's feelings about end of life. But I would say that I'm sometimes surprised that actually the patient or the family was really ready and or knew that we needed to talk about it. Like they're almost saying, I'm so glad you brought it up. I was sharing at a senior living home recently, and I had a lady come up to me afterwards and say, I've been wanting to stop dialysis. And I wanted to talk about hospice. And you know, I think we just don't know where people are in being comfortable already, or just knowing that they're in the process or getting closer to dying. So, and I'm just reviewing this, that Medicare says that if a doctor deems that a patient has 6 months of life or less to live without any medical treatment, then they recommend hospice.
And I would say without any aggressive medical disease modifying treatment.
Yeah, thank you. Thanks for adding that. Yes. So I think it's easier to identify patients in the last week of life. It's easier to identify patients more accurately the last month of life. It's a little bit harder 6 months before to identify them, but if we can, then they could potentially get, they could have time to get used to the idea and accept the idea of having hospice on board. And one thing I will also say is they might not initially say yes. You might share hospice with them and they might say, nope, I'm not going to do it. But a week or two later, when they're having some symptoms that they need help with, they might say, hey, you brought up hospice. I'm ready to talk about it now. So I really feel strongly about planting the seed, even if it doesn't have the results that you think immediately. It's important to go ahead and open up that conversation. And I say one does not have to feel ready for hospice to be eligible to receive hospice care. I took care of a lady in her early 60s last year, and she had a skin cancer that had progressed and it had moved to her lungs. And I remember her first conversation with me was, I don't need you. I don't need your help. All I need is my pain meds. And, you know, that is all she needed from me. I said, I can come once every other week. You know, if you need me more later, well, you know, you can call me if you need me. Well, you know, her overall goal, she lived alone, was to be as independent as possible till the very end. And we had her on services for 9 months. She got to live in her apartment up until when we needed for her to go to our inpatient unit for care. And she passed away at our inpatient unit. She wanted to have a garage sale. She had like 2 wishes: to have a garage sale and to go to the beach. Hospice was able to help her do both of those things. She did need us, but she wasn't ready for us. But by opening the door, we were able to build a relationship of trust and help her out with the things that were very important to her. Let the people know, and I think this goes back to what Holly shared. There's a lot of misconceptions about hospice because of people's hospice experiences. And so we need to be ready to tell them the truth about hospice where there's myths that they have believed in the past. And I think that just letting them know that they can receive hospice care wherever they call home, there doesn't have to be a change, that it'll just be an extra layer of support that we can add to wherever they are.
So I'm going to talk about the SPIKES acronym for the hospice conversation. There are lots of acronyms out there for having conversations. This is just one of them. But I think it, you know, so if you can find what you're comfortable with in having difficult conversations, stick with it. So the S for the acronym is the setting. Before we have difficult conversations, we really need to kind of review, like Erin was saying, prepare ourselves, review clinical records, think about what changes we've seen, and then provide a setting with some privacy. These conversations don't need to be addressed as a family member's leaving a facility. You need to have the right amount of time. So limit interruptions if possible. If you can take them to a private room, if they want to have this conversation with other family members, invite the other family members and set a time and a setting that's good for everyone. And then in the setting, sit or stand at the level of the patient or the family. Just that establishes rapport and puts you on the same level as them. The P is for perception, or what the patient and family know about what is currently going on. When my mother was referred to hospice, I mean, she was close to dialysis. She was in fluid heart failure. She had advanced cancer. It was no surprise to me that somebody brought up the subject, especially being in hospice. But I'm glad that they asked my understanding of what was going on. You know, ask what changes they've seen. Ask what they've, you know, the difference in like the ambulation activities, the daily living, what changes they've seen. say, last Christmas, what were they able to do? And, and what have you seen that they're able to do now? Listen to their level of comprehension and kind of go with your conversation on that level. If it's a very low level of comprehension, then, use the least medical jargon possible. And denial is fine. It's not needed to be confronted during these conversations. Denial is a normal part of life, and people go back and forth even after they've been on hospice. They have days where they're in denial and days that they're accepting. It's not a smooth continuum. So after you've kind of got the feel for what they understand, the I is for the invitation. Ask permission to have the conversation about hospice. Ask if it's okay to have a discussion about changes that you've noticed in the family member or in the patient. If the conversation's declined, accept that this is a difficult conversation. Like Erin said, sometimes just getting to that point and planting the seed, and they know that you're noticing things, they'll come to you, usually sooner than later, to continue the conversation. So see if there's a better time if it's declined, or if they'd like to have other people. But if they want to keep going in the conversation, then share the knowledge that you've seen. Briefly summarize recent events. I've seen that your mom has gone to the hospital 3 times in the last 2 months for urinary tract infections, and that she's had to be on medicines to keep up her blood pressure because these infections have been severe. Paint the picture. I wish this wasn't occurring, but I see this as a continual in and out of the hospital process. And then at that point, you can kind of talk about goals and introduce hospice as an extra layer of support to support the patient and the family. Introduce hospice as something that might be able to help keep them out of the hospital, or introduce the thought that maybe they don't have to treat the next infection. They can just keep the patient comfortable. Hospice, does provide medications related to the patient's decline, just not aggressive medications, not dialysis, generally not TPN, every once in a while. So introduce what hospice can do and how it can benefit the patient and the family. And then at that point, it might be a good idea to ask them what they've heard about hospice in the past. Have they had the experience of a family member or a friend that's been on hospice? A lot of times, this is when you're going to get the myths. And the myth that, well, my friend's dad was on hospice and he died the next day. All hospice does is, drug people up until they die. I mean, there are a lot of myths out there. And during this knowledge part of the SPIKES acronym is where you can share a lot of knowledge of how hospice can help the patient and family.
And I would add, Dr. Godfrey, to just that it is important for us to be direct when we're summarizing the things that we're seeing. I know a lot of times I'll get well, why didn't someone tell me they were dying? And it probably isn't that you're the first person to introduce some of these declines. But like we said, since denial is there a lot of times when we're in a state of denial, we don't accept. We need people to be direct with us.
Yes.
So that we can really hear it. And sometimes we need it to be said more than once to really hear it.
And then at that point is usually where the emotions come in. and validate them as they arise. And if they're just floored, give them some space, give them some time. Maybe even ask, what do you think about this? How are you feeling about, the fact that I brought up hospice? Some people just, this was the elephant in the room and they knew it was coming and they're relieved. Sometimes you're going to have anger, and that's okay. And over time, you realize that anger is not directed towards the conversation or you. It's directed at their, just their frustration of the disease process. So use empathic listening and empathic statements. I feel you're shocked by this. I see that you seem surprised by this news, or you seem relieved to have this conversation. So just give emotions some space and time. And go ahead, Erin.
I was also going to add, actually, I'm going to wait till you summarize because
Okay.
I'll do it on that piece.
So the S is summarize and strategy. You got to, this is a conversation that you kind of got to wrap up. So summarize, the changes you've seen, what your recommendations are, what their goals are. Ask them, if it's okay if you talk to their physician about writing a hospice order. The hospice order can be for evaluation and admission if appropriate, or sometimes just ask them if it's okay if hospice comes and talks to them and shares what they can do.
And on the goals, I would say, especially if you are talking with a family and the patient isn't able to participate in the conversation, maybe because of dementia or other disabilities, or just that the disease has progressed so far, I think it's really important to ask, what would the patient want? There's often, when the patient isn't able to participate, I think there's a lot of guilt sometimes about choosing hospice. And so going back to, what would the patient have wanted? Do you know what they would have wished for at the end of life? Would they have wanted to pursue aggressive treatment and go to the hospital and do whatever possible to live as long as possible? Or would they wanted to have been kept comfortable and stay at their home? So I think that it's helpful to the family if we can, draw in what the patient would have wanted.
And then in wrapping up the conversation, we need to reassure patient and family that hospice comes in and helps the primary caregivers. Hospice comes in and helps educate and teach, whether it's a family at home, whether it's the staff at a facility, whether it's somebody in a group home. So reassure them that hospice is an addition to their primary caregivers at the time, whoever that might be. Let them know that they'll be contacted by hospice. Let them know that they can even contact anybody, the patient, family, or even patient care managers, referral sources. Feel free to call if you have any questions. If you're concerned that somebody that you know and love, or a patient that you're caring for, might be starting to become eligible for hospice. This is such a benefit, and we frequently hear after a patient's passed away, a lot of times right at the death, or in cards that we receive from families later on, so many times we hear, we wish we would have started hospice sooner. I've never had anybody say that they wish they had deferred this conversation or hospice care. And to Leah's discussion about advanced care planning, or even just advanced discussions, it's such a gift to the family if they've had these discussions beforehand instead of in a crisis. I see patients at our inpatient unit. I see patients and family all the time. And there is a vast difference between family members that are trying to make decisions based on what their family members know, and family members that are making decisions because their loved one has said, I don't want any aggressive measures at end of life. And there's just a bigger sense of peace that they can enjoy that transition and crossing the finish line with their family member if the plans are known in advance.
Yeah, I would agree. And I would also just say, just to encourage all of you, like, we can all be a part of this conversation. We all need to be a part of this conversation. And even when we feel awkward or the conversation is not received the way we hoped it would be, I can't tell you how often I'll go out and have a conversation with a family on Thursday. It will not go well. I will think that they didn't want to listen, they weren't interested, they didn't understand. 24 hours later, they'll have a conversation with someone else and be ready. So, I always like to think that we are a part, we're all doing this together. We're a part of a great big team and helping humanity and our community. And so the part you play in sharing or being the first voice, it's an important part. And I just want to say, like, have courage in having the conversations, because the benefit that it can be to families and patients is huge.
Yeah. Thank you so much, Erin and Karen. I really appreciate you guys emphasizing that. We've come to say at Care and Prepare that, in sickness and health, it's really the best gift that you can give. So it's a good gift any day, and especially if you don't need it. It's wonderful to be prepared in advance. Like you've clearly stated in those stories, many times people are like, yeah, we're not ready for it. And then we change our minds, and sometimes we do need something and we need resources on a dime. So it's good that you guys are being so proactive in the community. Thank you.
Even just last week, Erin, as we were preparing for this talk, Erin was talking to me. She's like, I met this family at the hospital and I just don't feel like I connected with them. But 2 days later, she planted the seed, and 2 days later, I saw that the patient went home on hospice. So,
never know when somebody's going to water that seed, especially like we had the other day. That was a real gully washer. So
exactly.
That's right. And I would say too, just to us that are in healthcare professions or helping professions, let's lean on one another for support in having the conversations, and we do that. We have these conversations a lot, but I still call Dr. Godfrey and say, you got any advice on approaching this? How do you think I could approach this better? And so we're all growing in how to do it, and trying to do it better. But really do appreciate that there's not just one of us trying to have the conversations.
And lean into these conversations. I hear so many people say, well, I'm just scared. I'm not sure how they're going to respond. But I feel like if you just lean into these difficult conversations, you will see afterwards how much you blessed a family by acknowledging probably what they already know, but if not, planting the seed.
Absolutely.
So at this point, we're going to open it up to questions, and either just unmute yourself and yell it out. I'm going to stop sharing. And if you're not comfortable yelling it out, we'll check in the
there are a couple already
in the chat. Okay.
So I'll read off the question. My dad and this is from Patricia. My dad stopped wanting to go to doctor's appointments for his prostate cancer and kidney issues. So I asked if he wanted to stay home and have a nurse come to him. He said yes, and so we set up hospice. His last 4 months were very peaceful and he was at home. Would you explain what medical care will be continued and what will be discontinued?
Well, hospice is responsible for covering any medications that are related to what's called the terminal prognosis. So it's not just medications related to his kidney issues, but if there's if the kidney issues were due to hypertension, we would be responsible for covering those medications. Diabetes, then diabetes as well. Hospice is paid. I'm Holly. I'm sad I couldn't listen to you last week, but hospice is paid a certain amount every day to cover everything: medications, nurses, psychosocial, spiritual. So we do try to be good stewards of that. And if there are medication adjustments or deprescribing that can be done to prevent medication interactions, we will try to do that. If you talk to one hospice, you've talked to one hospice, because everybody kind of does it a touch differently, but really hospice is required by Medicare to cover everything related to comfort and the terminal prognosis.
And it does include nurses' aides that come out and help with personal caregiving. That's something that you don't usually get through home health, or you get a very limited amount through home health. So that's one of the services of our team.
From Kathy asked, what role might spiritual or professional advisors play in suggesting the hospice conversation? And is this framework that only healthcare providers should initiate? Not at all. No, it doesn't have to be healthcare at all. I've been in situations where we know that there are cultural differences, and we have asked the spiritual counselor to come with us to conversations, or sometimes it's the spiritual counselors that are suggesting that the patient or family give us a call.
I have recently had, I think because of COVID, lots of people have turned to their pastors or their ministers at their church or spiritual communities, because I've had lots of families tell me that it was their minister that told them and talked to them about hospice first.
And then how do we talk to about hospice to a patient who is not ready for hospice, but the family is? That's a difficult one. A lot of, and we talk to them, we say all that we can provide. We don't like to advertise that people can sign off hospice, but, we sometimes will ask for like a time limited trial of, if they're having a symptom, give us a chance to help you with this. And then also sometimes we stress the value that we are helping their caregiver, because the caregiver is so stressed out or so burnt out. So sometimes we approach it in that direction as well. And then the opposite, when a patient is ready, but the family is not. Those are tough situations. Sometimes we have patients sign up for hospice and not even tell their family members. And then we have to help deal with the, but the good thing is our psychosocial staff can help deal with the fallout or help the patient in how to present that to their family, and help with the family when they're told.
And I will say, I had been a nurse a long time before I worked hospice, but I had never worked with a team with social workers and spiritual care professionals. And, the hospice is so holistic. Yes, we manage physical symptoms, but I can't tell you how much healing I've seen come in family relationships through the help and the assistance of the social worker and chaplains. I mean, literally, so some of these things do work themselves out. Initially, it's very difficult to have those conversations and invite the patient to consider the family, or the family to consider. There's so much brokenness, and it all hits the fan when crisis happens, right? And so it is difficult, but I think we do have more resources than just the healthcare professionals. We also have social workers and chaplains and
sometimes the ones that provide the most psychosocial support are our home health aides. They've done this thousands of times, and they, just in the care that they give, provide more support than the medical could ever. Vicki asked, some families want hospice to admit a family member and not tell them that they're on hospice. Well, if the patient is competent, we can't, if the family member is competent to make decisions and they want to be a part of their healthcare decisions, then they have to know that what they're signing up for. Now, sometimes you will, in some cultures, if the patient is totally competent and they tell you, I don't want to know anything, and this is my decision maker, it's a little bit different. It's a tough one to navigate through. We have people that say, cover up your badge when you walk in. We don't want to hear about death every time you come over. So we try to tread lightly on those situations and respect the family and the patient's wishes. But if the patient wants to be a part of their healthcare decisions, and then they have to know what they're signing up for, because you sign consents to be admitted to hospice.
We ease some people in, though. I would say we do try to ease people in to the idea.
Could I ask a quick question? I can't put it in the chat. I don't know how to word it, but is it my mother's placed in the Dallas-Fort Worth area in a nursing home? Some of this sounds familiar. That is she could be here in 6 months? I think sounds familiar. But does a doctor initiate the hospice, or do we initiate that, or is there obligation for her primary to approach us, or who initiates it?
I would suggest, well, anybody can initiate the discussion, but you would need to talk with the caregivers, and because there does have to be a physician referral to get admitted to hospice. It can be, a lot of times that referral comes like if the patient's been in the hospital, or their primary care, or facility attendings. Sometimes it's emergency room doctors.
But the nursing home doctor or nurse practitioner often does write that referral, and the family can come and say, hey, I'm wondering if, what do you think, is it time for hospice when you look at the decline that my mom has had, or the family can initiate that conversation.
Yes, definitely.
But if we kind of don't see, because of COVID, we're not in there quite as much, the doctor will initiate if we don't see it and they see it. I mean, hopefully they'll initiate that.
Maybe.
You would hope so, but you might even just ask the facility staff, hey, do you think it's time to have a discussion with the physician?
That's a good point. We kind of need to do that. Okay, thank you.
Maybe, and maybe even ask for a plan of care meeting, or often it's the nurse on the floor, or the nurse's aide on the floor that might be seeing the changes. That might be.
We do have the care plan meetings, but the head nurse, that would be something I could ask her. Thank you.
Definitely.
Holly asked to explain what TPN was.
Oh, I'm sorry. I didn't. What TPN is? Oh, TPN is total parenteral nutrition, which is basically feeding somebody protein, carbohydrates, and fats through their blood vessels, which generally is not in line with comfort care only. And the big thing about TPN specifically is it requires usually daily labs and adjustments of that medication. Some hospices will do some, other hospices won't. We have provided Clinomix, which is just the protein and the carbohydrate for like a mother that wanted to make it to her daughter's last rodeo. If they have a goal of making it, and this, IV fluids or nutrition is going to help them to this certain goal, then that's something to be considered.
Thank you, Dr. Godfrey, for explaining that. That's a conversation I have probably more than any other question. So I thought, let's hear it from you. And with dementia, I spend a lot of time using that sentence. They're not dying because they stopped eating. They stopped eating because they're dying. That type of thing. So thank you I just thought not everybody's going to know what that means. Thank you.
And that's probably one of the conversations that we have very frequently is the nutrition and hydration conversation. And like you said, they're not dying because they're not eating. They're not eating because they're dying. And I tell family, that's so much. It does not cause a patient discomfort. It causes us discomfort because culturally, that's how we take care of people. But when that discussion occurs, usually it's the time to say, let's switch our focus. And there's a lot of other ways that you can provide care. Just them hearing your voice and you being present is providing care.
And I use a lot with that also, that the body knows how to die. The body knows how to shut down, just like the body knows how to be born. And I use that a lot in that dying is a lot like birth, that it isn't like TV, and it usually isn't like that, and that sometimes it doesn't look good, sound good, or smell good, just like birth doesn't always look good, sound good, or smell good, and that it isn't what it's been portrayed to be on my favorite Grey's Anatomy.
No, not at all. And we have those conversations frequently as well.
I think one of you mentioned transitioning, helping people get used to the idea. What have you found to be maybe the best way to help someone transition to the idea of hospice care? Is there one way more successful than another, or?
I think having more conversations about it is one of those ways. And maybe
Give us a trial with the pain relief. Is that one been a good one?
Right. I think, and yeah, Dr. Godfrey did say, we'll tell people, well, you could try hospice and see if that, if your symptoms are better managed. I think, because they've had strange experiences or ideas in their head, or even just the thought of people coming into your home every day can seem very strange and overwhelming. So I think attaching faces and building some trust helps people transition.
And knowing that this doesn't have to be doom and gloom and all sad. There's a lot of joy along the journey,
right,
that families experience with hospice, families and patients experience with hospice.
Well, that is so good, because I really do believe you guys add quality to life and to the days that we have. And we all want to live all of our days as well as possible. So thank you.
Thank you all so much for the series. Thanks to Care and Prepare and Community Healthcare, and of course, James L. West. And thank you for everybody attending. We appreciate this. We hope it's been helpful. We hope you have some new ways to have the conversation and what to ask and the paperwork that you need to put in play and dispelled any myths that you might have had. Again, you will get a follow-up email this afternoon with the recording for today, copy of the slides, how to get your CE credits, and past information from the rest of the series. And also be on the lookout for upcoming programs that we're having in June as well. So unless there's anything else, we appreciate everybody's time and hope to see you again soon.
Thank you.
Thank you all.
Thanks, Jamie.
Thank you.
I'm really glad we all got the pink and blue memorandum. So I'm the only one that added another white and beige to it, but
Got to mix it up a little bit.
exactly. Thanks, Jamie. You always do an awesome job.
Thank you. Bye.